Next, would you please welcome Dr. Eric Mallack from Kennedy Krieger to talk to us about ALD standards of care in pediatric neurology.
Hi everybody, it's nice to be here. Thank you for the invite to come back and talk. I still have to get used to hearing Kennedy Krieger after my name, but a little bit of an adjustment. So I'm going to talk about the standards of care for MRI monitoring, and talk a little bit about imaging, and I'm hoping some of this can become a conversation given the population in the room. So these are my disclosures. And so, like I said, we'll talk a little bit about MRI surveillance, talk about some of the insights into early stage lesion development, timing and treatment, and then in the end I'm going to present a slide from data that I dug up at Hopkins. Oops. So really quickly, I am one of the people responsible for this relatively onerous MRI screening protocol. So you are welcome to blame me. But this is what we're trying to avoid capturing. So this is one of my patients who was referred to me who had a less score of 9.5. And in going back through his MRIs, which were previously called normal, he was 2 years and 5 months old. And I don't know, does this pointer work? Oh, I have to turn it on? It's a good first step. But you can clearly see this patient had evidence of disease at 2 years and 5 months old. So as we go along the way, I'm going to start to point out the observations that are coming to the fore in sort of detecting early stage disease. So we did some work, 5 or 6 years ago now, looking at what we're trying to capture with ALD newborn screening. We are trying to capture tiny, very subtle lesions that then grow into what we understand cerebral ALD to be over time. So this is just another shot for those of you that don't look at MRIs all day, every day. This is mid-sagittal view, and this is essentially a cross-section through a small lesion. Here it is again, and then you can see the tiny bit of enhancement, and that's our trigger to take a patient to bone marrow transplant, gene therapy, etc. And so this is what we know, and this is what everybody knows. So advanced versus early stem cell transplant. If you have advanced disease, a less score over 9 or 10, patients will generally survive the transplant, but the vast majority of patients will accumulate major functional disability, whereas if you transplant a patient prior to symptom onset, not only will they live, but the vast majority will remain relatively symptom-free. So because there's no genotype-phenotype, I know a lot of you have seen this slide already, but this is the setup. We identify a patient by newborn screening. At some point there's lesion onset. At some point later there's symptom onset, so there's this period that we know of silent lesion growth until it gets sort of large enough to actually cause symptoms. And the thought is that's usually around a less score of 10 or above. If you ask the Minnesota group, they'll say that the symptomatic cutoff where they start really becoming clinically symptomatic is 10. And so these are the two conceptual time periods, and we know that if we transplant a patient in the pre-symptomatic time period, they do well. So we take these pictures, try to capture an early lesion, and then get a patient into transplant as quickly as possible. So at the time when we were putting together these guidelines that Dr. Adang was mentioning, which I agree will need to be optimized over time. I think about this quite often. But for what we had a couple of years ago were the data that were in the literature. So we went and did a meta-analysis, and we tried to figure out all comers what was the median age of diagnosis of cerebral ALD. So in the textbooks it's 7 to 8. This is a mixed symptomatic and asymptomatic cohort. So the median, 90% of cases were between the ages of 3 and 12. With a median age of 7. And I want people to keep the median age of 7 sort of top of mind, because as you can imagine, the earlier you detect disease, you'll find out that the actual diagnostic age for cerebral ALD is earlier than that. So we developed these guidelines, and really, this is really the most onerous part, really between the ages of 3 and 12, performing an MRI every 6 months. So this is what we're doing now, and as someone who worked to put this together, gosh, 4 years ago, with the effort starting far before that, what have we learned since that can help optimize how we surveil for cerebral ALD? So what you're looking at here is our lesion volumes of very small early lesions mapped out per patient over time. And in the red are patients who had progressive cerebral ALD and then went to transplant. I know these curves are steep, but what I want you to know is these patients have a less score of 1, 2, 3. These are small lesions. The goal was just to understand what were the features of their growth and what can they tell us about who's going to progress versus non-progress. And then there's this cohort of patients when you get out, and I'll define this a little more, that seem to have what we call arrested disease. They self-stabilize. And we can have a conversation, if you'd like, about how we know that. But if you zoom into the 0 to 18-year-olds, you'll see that, and again, these are very small lesions. By volume, they pick up and then they start to exponentially take off. Whereas as you kind of get older, your lesion volume sort of stays stable over time. So if you map out the rates of growth for progressors versus self-halters, and this is data that we published back in 2018, these are the self-stabilizers. They have a rate of growth of essentially 0, but the younger kids, really under the age of 8, are the ones that grow. So this is sort of what we know. So we did this in a larger cohort and verified these findings. And I'll tell you one of the other features about this, about early lesion growth, especially in the boys under 10 and really the boys under 8, is not only do they move faster than lesions in older boys, but they tend to accelerate over time. Again, these are small lesions, but if we, over 2 or 3 scans, pick up something relatively small, and you're in the right age group, and we can demonstrate acceleration, we have a high degree of confidence that you should go to transplant. And we can talk about why that's important and how contrast kind of comes in and out of the picture. Any questions so far? Yes. Yeah, Keith.
Hold on.
I like this to be conversational because I just hear myself droning on and it's super boring. So, yeah.
Go back to that slide. So that looks like it may not be the best fit line. Is there maybe a polynomial fit that might work better?
So here's a general issue with a lot of imaging in rare diseases. We just don't have enough scans. So when we fit the model for some of this growth, I didn't put the slide in, but when we fit the model, we generated a linear approximation. We said the lesion volume roughly doubles every month. But it's a linear approximation of something that's clearly exponential. But that's just it's a limitation because we just don't have enough scans. So last night over dinner, I got asked by multiple people, well, why aren't we using AI to do this? And the Mass General group will know. That's right. So the Mass General group will know that we actually tried this in 2018, 2019, and the limitation was the segmentations were off because there just aren't enough MRIs. Whereas if you're in stroke or MS, you can get tons and tons and tons of scans, feed and train a model, and it does something with relatively high fidelity. Ashish.
Here's the mic.
Thank you. So for the arrested lesion, what was the time duration? Over what time duration did you measure those lesions? And did you notice any particular areas that were involved, or were they the typical paradoxical distribution?
Sorry, so what was that? So all of what you're seeing here are all the scans for these patients, and all of them effectively went to transplant or gene therapy. So the total follow-up time,
Including the arrested ones?
including the arrested ones were just what we had, so
Okay.
we would, this is for the patient population at Mass General, and we had teenagers, patients in their 20s, look back at all of their scans, and then I segmented all of their scans. But the median follow-up time for the arrested patients is on the order of years. I mean, it's years, yeah.
So
yeah.
what I want to really ask is that was there any patient in the arrested group who eventually progressed and needed a transplant or gene therapy?
Yes, so the answer to that is yes. We can get into a larger conversation about adult cerebral ALD, which is still a complete mystery to me. What we learned in that study was the majority of patients with lesions will remain stable for long periods of time, and you've had this experience. The only risk factor that I found in that study was if you have more than 2 or more areas involved in your brain, your risk of flipping into contrast enhancement went up by a factor of 3. So for example, I had a patient, he was 34 years old, had a splenial lesion forever, and then slowly started developing internal capsule disease. Scanned him 2 months later, expecting to see enhancement. We saw it, and you guys actually transplanted my patient. So, but those are the sort of things you look for, and they're intuitive, right? You have more burden of disease in your brain, so unfortunately, what comes with that is the natural history. But being able to predict out of all of these patients here, who's going to do it, I don't know.
Right, and especially the one that caught my attention was the one that, progressed and then arrested.
Yeah.
So, and it's a tough call because when
Right.
you see that kind of progression, you attempted to intervene.
Right. Now, I want you to know that this looks really dramatic on paper, and the math looks pretty dramatic. You look at the scans, and they're tiny, and people go, oh, it looks like it's the same size. When in fact it's not, because you're essentially measuring a sphere, and so a little bit of growth in radius, you get a squared value. So that's how you get more, right? They always tell you to order a large pizza instead of 2 medium-sized pizzas because you get more pizza, right? So, because that's how the math works out, right? Yeah.
That's a New York analogy, I'm assuming.
Right. I don't know that I recommend getting pizza in Minnesota, but
Eric,
Yeah.
can I ask you a question?
Yeah, I'll stop
So
talking about pizza.
when you're looking at this and you're, like you said, to the naked eye, it looks unchanged. I worry because it is a picture that you're taking. I remember when I was pregnant and my daughter was going to be 8.5 pounds. Spoiler, she was a little over 7. So it is an estimate. So especially if you're talking about, in reality, a very small change, it just seems like it's difficult to be super confident in it.
I know, so I agree, and I think you're right. This took a lot of figuring out about how to do it through the software. And after I did the first patient, I was like, wow, this is what it looks like. But after, there's 30-something patients now in this data set. When you start getting the same answer over and over again, then you're kind of, I think there's some good confidence built into that. But I do see what you're saying, and you'll see even some of these cases. You do get some changes. Like this patient here looked like they were going to be completely active, and then probably some of the swelling went down, became a little more swollen again. And you get this, or a slightly different cut. That's exactly right. So there are definite limitations. This is only meant to be the value of this data is to give us the features of lesion growth that tell us that we think you're on the trajectory for a transplant or gene therapy. Yeah.
When you're using this as the control to an intervention to say that the growth is not in line with the natural history, how do we know what the error range on these measurements are so that you could tell that you're not falling that?
Great question. So I didn't put that slide in. I can show it to you. We have the error bars on it. The full change per month is 2.5 with a range of 2 to 2.9. So that's the 95% confidence interval. Lesions, when you look at all the little slopes for velocity, and you actually calculate the acceleration and then do the group calculation, lesions in the progressors, the acceleration is 0.1 cc's per month squared. with a range of 0.05 to 0.14. So we do have measurement error. The clear part, I'm not so worried about the numbers. It's just that it's a non-zero number, and it tells us something about what the disease is doing. And this is not to be used clearly by itself. Okay.
Eric, may I have
Yes.
a question?
Yeah.
So I have a question and a statement. My question is, when do you start seeing contrast enhancement?
Mm-hmm.
And my second is the statement of, this is a call to arms to collaborate.
Mm-hmm.
We need more images. We need to share them with Eric. We need
Yes,
to
yep.
share across consortiums so we can refine this data so we can actually use it as a
Sure.
clinical prognostic indicator, because it's fascinating right now, but we need to turn this into practice.
Right, I agree, and I love the idea. Please send me your scans. Part of my charge at my new job is to build out the national imaging database. So that's the pipe dream. We'll be able to do it with your help, definitely. All right, so I'm going to move on a little bit to get to your other question about contrast enhancement, which is important. So what are some new things that we learned? Another important question, what I thought was another important question is, when we do this, we want to ask the question, like, how long is this? And no one's going to do the experiment where you diagnose a kid with cerebral ALD and then you just kind of sit on them until they become symptomatic. But you can back your way into this with help from your friends and collaboration. So, and Anna Torrey is actually the one that put together all this data and did all the calculations. Give credit to her. And then Keith helped me conceptualize how to make this work. So what we asked was, we asked three basic questions. What age do asymptomatic CC-ALD lesions first appear? What's the time from lesion onset to the first evidence of enhancement? And then once you have enhancement, which is your trigger to go to transplant or gene therapy, how long does it take? And then you can kind of add those times together, see what the clinical outcomes are at each point, and then get a sense of how long you actually have to treat. So one thing I want to point out is, in the cohort, this is a multi-institutional cohort with lots of patients, half of the patients showed up with a T2 lesion and no enhancement. Half of the patients showed up with a T2 lesion and had enhancement. So we called this group the delayed enhancement cohort. So it's not necessarily the case that if you're diagnosed with early stage cerebral ALD, that you'll actually have evidence of enhancement. There are kids with clearly non-enhancing lesions. So the median age in this pre-symptomatic subgroup of lesion onset was 6.4 years old. So from the literature, which was mixed symptomatic and asymptomatic, the median age was 7. So we gained half a year of lead time just by looking at the pre-symptomatic cases. And then if I limit this data set down to a diagnostic less score of 0.5 or 1, so the earliest of the earliest, the median age is 5.8 years old. So we actually gained a year in terms of diagnosis. We know that the lesions show up. And then the first case I showed you is the youngest case I've ever seen, which was 2 years and 5 months old. So really a shift to where we should be looking, and then as a field thinking about how to optimize our imaging guidelines around when are the points of highest sensitivity to detect really pre-symptomatic cases. So for the patients who don't have contrast at diagnosis, on median, it takes about 6 months to show up. That's the cumulative incidence data. What's important, and for those who want to have a clinical trial and to see if there's effectiveness, Katie, we were talking about this last night, in this cohort of where the patients did not have lesional and, was that me? I didn't do it, I promise.
When you
It's right, I can just yell, yeah.
no, say they won't hear you online.
Oh, okay. Oh, we're back up? Okay, we're back up, all right. So in the kids who were diagnosed who did not have evidence of lesional enhancement on their first abnormal scan, how long did it take to show up? It took about 6 months. If you look at the youngest kids who have a diagnostic less score of 1 or 0.5, it takes about 4.7 months. So they're the ones that show up a little earlier. But what's important is if you're going to build a clinical trial and you want to see if your drug's effective, in the natural history, 82% of patients developed lesional inflammation by 18 months. So if by 2 years out you give somebody a drug and only 50% of the patients converted, that's a deviation from natural history. Whereas if you give some intervention and all of them still convert by a year and a half, you have not deviated from natural history. And then once you have an enhancing disease, we treat patients in just under 4 months. That's what the field's been doing. And like I said, this is data from across transplant centers and leukodystrophy centers. I'm not suggesting that we do this, but the original question is how long is that treatment window? And these are kids, again, who have really early lesions at diagnosis, a LES score of 1, 1.5. All patients were treated by 15 months. They tell you in statistics, don't interpret the tails of cumulative incidence curves or survivorship curves, but I'm going to point this out maybe to be a little controversial. Even at 15 months, 96% of the patients were treated. They were still asymptomatic. 15 months, excuse me. I'm going to be very clear. I am not saying that we should wait a year to treat patients from the time they are diagnosed. But this is one way, Laura was talking about this, going through EHR data and going through the medical record to help answer your question. You can back your way mathematically into the answer. When I subsetted the data to the patients who had a diagnostic LES score of 1 or less than that, 0.5, the median time to treatment was essentially the same. It was just under 4 months. All the patients were treated by a year, and all of them were asymptomatic at treatment. So I'm not saying that cerebral ALD is not an emergency. It clearly is. But in terms of timing, this is what we're learning, what we've learned from the literature.
Sorry. And then for the person that's 15 months, say, are they still symptomatic a year later?
I don't know.
Oh.
Yeah. When I collected this data, I collected very specific time points, completely de-identified. Yeah. So one thing about validation of data in rare diseases. So I found out that Josh Bonkowski, who runs the Leukodystrophy Center at Utah, did this same analysis. We had no idea we were both doing this at the same time. Did the same analysis, except he used a different data set with totally different ALD patients. And he came up with the same answer, just under 4 months. We treat patients just under 4 months. So there's not a lot of validated data or at least repeated data across multiple scientific methods that come up with the right answer in rare disease, but I'd like to point out that this is one of them. How am I doing on time? Poorly. Okay. So this is the last piece. Usually, if you look at patients, patients who are followed at major centers, you have one of two categories. You have patients who are identified by newborn screening, who are treated with early disease, or you have the late stage patients. There's not a lot of data where you've sort of followed really early disease patients until they became late disease without some form of intervention. One of the ways that happens in medical practice is when a patient's lost to follow-up and comes back. That's sort of how that happens. So this is that patient I referred to earlier. When he was 2.5, he had a LES score of 2. I'm not showing it to you, but he also had some disease higher up in his genu. And it took 3 years to get him to a LES score of 9.5. So that kind of gives you a sense of the change in LES score per year. There's a paper from the early 2000s that looks at change in LES score per year, but doesn't give the actual data points. So one of the things I like to do when I spend time at institutions is rummage around in their old data and see if I can find something that's valuable. And so this is from KKI. This is the first time I'm showing this slide, and I want to highlight this disclaimer first. The analysis is ongoing; it's not published, and that really means that the data is really rough at this point. So take everything with a grain of salt. But this is data from 43 patients with childhood cerebral ALD with a mean with a mean number of scans per patient of about 3. And so there's 143 total MRIs on this spaghetti plot. And these are kids who went untreated. So these are patients from a different era. This is late 90s, early 2000s, where stem cell transplant still was in its infancy, and there were plenty of patients who actually just didn't undergo it at all. But what you're getting here is, this is the total MRI here, this is the LES score. This is the change in LES score per patient over time in untreated patients. And you can clearly see, we define early stage disease as a LES score less than 9. Clearly, all of these patients started as quote unquote early stage disease. And then this is what their LES scores do over time, untreated. So I'm going to contend that this is probably, and I'm going to contend that this is probably going to serve as a fairly good published control for trials moving forward. There's data in here from Mass General. There's data in here from Cornell, KKI, and then Dr. Dang, you promised me at least one or two patients. So, but what we'll see here is, if you remember the last curve with the volumetrics of very, very tiny lesions, those are the volumetrics of lesions that are way down here, tiny, tiny, tiny. But en masse, when you measure the LES score over time, you still get this sort of exponential rise over time until you hit around the age of 8, 9, 10, and then you get this little group, these self-stabilizers. So there's a lot of work to be done here to understand how these numbers change over time in a quantifiable and valid way. But what I'd like to point out again is, this is a different cohort of patients from a totally different era, from a different institution that I now joined, and we see the same signal. So I think the writing's kind of on the wall with how this behaves, and I look forward to kind of getting this out there. Okay, I think that's my time. So I'm happy to take more questions.